Hello, good morning, everybody. Thank you for joining me. I'm so pleased to get to speak to you about integrative medicine, and I appreciate in the context of lots of difficult things in the last few years that UVM included what I think is a really important topic for patients, despite all the other stressors of the healthcare systems right now. So I thank you to UVM. So we're going to talk today about complementary and integrative healthcare in the context of cancer. I wanted to let you know that my training, not getting my screen to advance to the next page. So I just wanted to take a minute to let you know briefly about my training. There are lots of people who don't know what a naturopathic physician is, and that is okay. I'm a naturopathic physician. I also have a master's degree in Chinese medicine, which confers me the right to practice acupuncture as well. So I went to school for a really long time. I've studied integrative medicine a lot, and my area of expertise is understanding where to find the best of both worlds and to use the evidence that supports that. Welcome any questions about my training later, because I know it's new to lots of people. The learning objectives for today are, I hope you leave here understanding how to prioritize lifestyle medicine based on the evidence. I hope that you leave here understanding what some of the risks are of integrative medicine and what the benefits are of integrative medicine. I start with this slide because even NPR can push people's buttons. So we have in this single screenshot, we've got controversy and outrage and should we eat red meat or not? And I'll circle back on this, but what I want to bring to your attention is if you're a patient, I know that you're getting your buttons pushed with this. And if you're a physician, we need to be super compassionate because our patients who are doing all the things that are right for them have to filter messages that talk about controversy and outrage. Once upon a time, when I started my training, we talked about CAM therapies or complementary and alternative medicine therapies. And now we talk more about complementary integrative therapies than alternative therapies. And the difference is really important, and to me, really important, especially in oncology. Alternative medicine suggests that there are two equal choices and that you get to just choose one. And alternative medicine conversation is, should I do chemotherapy or should I take this herb? And those are not equivalent. So we can't use that term. It's not appropriate to use that term because that's not an appropriate choice. What we've kind of evolved to say instead is complementary and integrative medicine, meaning if there are herbs that are safe and effective, we use them integrated with what we've established as the standard of care and the therapeutic medicine that we've established through years of research. So this isn't about us versus them or this mainstream medicine or this alternative medicine. What I'm presenting today is integrative medicine, which is finding the best of both worlds because we want our patients to feel well and be supported. The patient experience is really intense. Proactive patients are listening and paying attention, and they want what's best for them. And they are told by their friends, their cousins, cousins, that sugar feeds cancer, or that they shouldn't work out on a certain day, or they shouldn't eat at this time, or patients want to know how much exercise is enough. They want to know, is alcohol okay? Does it matter at all? Should I be vegan? Can I eat soy? What else can I do for myself? These are proactive people who want to do something. And if we don't help give them and guide them to the evidence, they'll find it where it's available, and it's often available in ways that are really predatory. Saying things like, here's something your doctor doesn't want you to know. Criticizing big pharma, criticizing toxicity of conventional treatment, using the term doctor for that may be appropriate in terms of the person's doctoral level training, but not necessarily in anyone who has any clinical experience. Testimonial evidence that's presented as if it's equivalent to more robust scientific evidence. And then treatments that are thousands of dollars and promise a natural or a miracle cure. In contrast is the physician's perspective in integrative medicine, which is also, really super challenging. Now, while there's a body of providers that do have integrative medicine training and integrative oncology training, it's a really, really small field. I would say there are hundreds of us, whereas there are thousands and thousands and thousands of people who have standard oncology training. So there aren't a lot of people who are trained to give such advice. And that makes it hard for the docs who don't have the training. And they can't have the training because you can't possibly be an expert in your specialty and then also be an expert in a different specialty and use both well at the same time. So you can't know all of the ins and outs specifically about surgical oncology and then know all of the facts and be up to speed on the research for integrative oncology use of herbs, let's say. The other thing that's really important is that my experience is that the patient's brain space in a visit can't handle hearing the results of a scan or the results of labs, and then also be thinking in the same visit about what strategies they're going to use to help their sleep be better. It's too much to carry through one office visit. And sometimes compartmentalizing is the right thing to do so that you give the patient the attention that they need for the thing that you're handling in the moment. So what do we do about that? We don't know. So I'm going to ask the questions here, but we don't know exactly what to do about that. But here are the questions. Who should be involved in integrative care planning? Who gets to decide if a patient uses integrative oncology care? What is the role of the patient in her own healthcare? Where should she receive that care and from whom? And then once we answer all of those questions, how do we talk effectively amongst us so that the patient stays safe and supported? And the goal is, first, standard of care. Second, give these patients who are looking to take initiative everything that they need, but doing it without risking their safety or risking the precision of the standard of care. These are hard things, and there are great strategies that we can use. I love this slide. I'm just going to take a minute here because these are my roots. This is my training, is to understand where herbal medicine becomes therapeutic medicine, or where an herb becomes pharmacology. And as I said before, I'm not an us versus them person. I'm a curious person, and I am a scientist, and I want to know the evidence. So these herbs that are on here, or these plants that are on here, you might know as Taxol, Podophyllin, Vincristine, and Irinotecan, but other people know them as the Pacific yew, or periwinkle, or the Chinese happy tree. And this is really, really important to remember that we're on a continuum of care, and people need to be met in different places. And for one person, this is herbal medicine, and for another person, this is pharmacology. And there's connection between all of these things. When medicine is disintegrated, patients might feel so fearful that they choose not to follow through on the care that's been recommended to them. And unfortunately, those of us in what was formerly considered the alternative medicine world have seen this a lot, where a patient delays her surgery or delays the start of chemotherapy because she's seeking the cure with something that she's found online. I will say that I have lots of experience in my clinic with this going not very well. And I feel like in a lot of cases, if there was better communication among providers and less us versus them, these patients could get the best of both worlds and feel more empowered to make choices with all the information rather than kind of holding up into one paradigm. And I have really tremendously appreciated the phone calls I get from oncologists at UVM saying, worried about this gal. I don't think she's going to do conventional care. We need to have a conversation. Proactive oncologists who are really concerned about their patients. And I love participating and helping. And patients have a right to make the decision that they want to make. But as providers, it's our responsibility to make sure that they have the information they need to make that decision. And when that conversation happens and it feels charged and us versus them, patients don't listen as well as when we take the walls down. So patients can make hasty and expensive choices. We miss drug-herb interactions because patients are not communicating or providers are not communicating. And it puts the burden on the patient to figure out what to do for herself. And that's great. I love my patients to be empowered, but I don't want the complete burden and the orchestration of that effort to be completely on the person who also needs to heal and get better. There's more. And this slide is a follow-up to the one before about the consequences of disintegrated medicine, because this is a slide that really motivates me to practice in this field. The emotional and mental distress from patients feeling analysis paralysis, like they have to really figure it out for themselves, is harmful to their well-being. Patients who want to do everything and therefore do so much that they are overwhelmed and stressed, lose sleep, suffer relationships, isolate themselves because they're trying to do too much. And most important to me is when we don't help patients coordinate this, the easy changes that mean a lot are missed in favor of the minutia that feels like it's making progress or getting traction, but the evidence may show big benefit here, that the patient's only doing something here. If we have the clinical perspective to help them organize and we integrate the medicine, we can make sure that the thing that's the most important is the thing that gets the attention. So, to physicians, ask, keep an open mind, explain the reasons for your concern, educate them on your experiences, monitor for the adverse events, recommend non-pharmacologic interventions if you know them and you're trained in them. And, you know, if a patient's having sleep trouble or leg cramps, we'll talk about it at the end, but magnesium is a great option. So if you know how to use it, consider it. And if you don't, refer to somebody who knows how to do it. But don't lose that patient because there's a breakdown in communication, because Burlington has a great network, in my opinion, for supporting these patients. So the person you refer to, what are they going to do? That person is going to understand the ins and outs of the diagnosis. Breast cancer is very different from lymphoma. They don't get the same integrative oncology care. They don't get the same conventional oncology care. So you have to be trained well enough to know and understand the diagnosis and treatment of the patient who sees you. You need to know what the patient goals are. What's their priority? Then you prioritize the interventions based on the evidence. So you have to be able to have time to read the evidence. And then you choose the things with the biggest benefit and the least harm. That's in medicine all the time. The goal is to reduce side effects. And in the 15, 20 years that I've been doing this, we have more and more evidence for integrative medicine strategies improving overall survival. Super exciting. Lots of places are doing it. University of Vermont, the regional hospitals here, Dana-Farber, MD Anderson, Memorial Sloan Kettering, many, many others. These are some hospital systems that not only include integrative medicine in general, but integrative medicine clinicians, specifically naturopathic physicians like myself, are employed at these hospitals and sit down with patients after they've established their standard of care, and they sit down with patients at these institutions and come up with that triage, that prioritization to make a plan that the patient feels comfortable about. I see myself as kind of the filter that comes after the patient establishes a really close connection with their oncologist. Then they see me, and then I help them decide, what do we do next? Is it Reiki? Is it acupuncture? Is it nutritionists? You as a patient can decide that for yourself, but if you need help, there are people with the training who can help decide when you look for the next level and how to prioritize. So if we do our job well, patients will have standard of care therapies. They'll have them on time. They'll have them with good optimal management of side effects. They'll have them with ideally very few delays of treatment. The patients will relax and trust that they are doing all that there is to do for their self-care in their journey. And they won't feel stressed worrying for what else or having the shoulda, coulda, woulda. And I want my patients to feel very, strong and empowered. So what's our evidence for this? Our evidence is from a lot of different places. And here's one example of where we get our evidence. This is a kind of a global study that looked at the effects, the relevance of lifestyle medicine, self-care. I'm just going to back up one. I touched it twice. So what they found, and I know it's probably, unless you're really close to your screen, it's hard to see some of the smaller words, but as you go around clockwise from left to right, it's recommending the things that we know to recommend. Be a healthy weight, be physically active, eat a diet rich in whole grains, vegetables, fruits, and beans. And I offer you this slide because this is a very, very 100-page document that explains the evidence for why the decisions are made to make recommendations that have been made. So we have evidence that guides this, this decision-making. Why lifestyle medicine? So I want to take a moment and tell you why I think this is so important. All of us, no matter how well we take care of ourselves, will come to the day or the time when something just doesn't go medically the way we want it to go. We find out something we wish weren't true. We get a diagnosis that we wish weren't the case. We have a problem, we have a complication. My advocacy for patient self-care, patient-informed self-care, is so that when that time comes, you have the best outcome possible in the circumstances you have. And I have more than one story like this, but I have a dear, dear patient who had a very bad experience during a surgery to remove part of an organ. And he said to me, I've taken care of myself my whole life. And then I go in for the operation and I almost don't survive. What is that? And what I said to him is, had you not been taking good care of yourself in all the ways you know how, you wouldn't have survived an intraoperative cardiac arrest at 86 years old. People just don't have the resilience to manage the reality of the stressors of medicine as well when they don't take care of themselves. So this is not a promise that nothing ever is challenging, but it is a wager that you'll manage it better. So I'll go through these and I'll share with you the evidence of each of these and how I think about them. But simply take a look for a moment and decide kind of which of these you want to focus on for the week, maybe. You can choose one, or wait till I'm done and then you can choose one. Sleep is super important. Our brain makes a hormone called melatonin, and melatonin is associated with sleep, but it does so much more than just help us sleep. In fact, I think it puts us to sleep so that it can do all the wonderful things, kind of like how sometimes I wait until my kids are asleep to clean my house. Melatonin gets triggered when we're in the dark and at the end of the day and as the sun sets, and bright blue lights interfere with melatonin, or lights that are LED lights with more of the blue hue. Drinking alcohol at night interferes with sleep, and blood sugar dysregulation can interfere with sleep. And sleeping well helps you tolerate treatment better. So For many of my patients, if they're sleeping in a dark room, not drinking too much alcohol, stabilizing their blood sugar, and what we're about to get to is exercise, we usually can get to the place where their sleep quality increases. And that's always one of my goals, because one of the things we know is that when melatonin is in our systems as it should be, lots of things get better. We now have evidence that bones are stronger when people have healthy melatonin levels. We have evidence that tamoxifen works better when people have healthy melatonin levels. We have evidence that people's esophagitis or irritation of their digestive mucosa from having reflux gets better when people have healthy melatonin. So it's not just about sleep, but preserving sleep, protecting sleep allows so many of these things to course correct. Exercise. So I was giggling before I started this recording because I was thinking things that I love. I love having a lemonade spritzer at the beach. And I love working in an oncology climate that really values exercise. And so I have such appreciation for the work that Kim Dittis and Patty O'Brien and UVM have done around steps to wellness, because having patients supported that way is so important to my goals for my patients, and I really appreciate them. If these words, steps to wellness or oncology rehab, are unfamiliar to you, I highly recommend you find out more about them. It's out of the scope of the time we have for this visit, and Kim Dittis does a great job, so I'll leave it to her. But evidence on exercise is evolving, and we're learning that, we study it and we learn more, we study it, we learn more. It used to be that we would say 30 minutes a day. Now we have evidence to suggest that for kind of middle-aged people like me, 45 minutes a day is actually the new target for better overall survival. Many of my patients come to me and they might be giving tremendous attention to their diet, or tremendous attention to how much sugar they eat. And what it often comes back to for me when I prioritize is they're usually not focused nearly as much on how they move their body than they are on what they eat. And so when I talked earlier about triaging or helping patients prioritize, exercise is usually one of the things that pops up on the list for the average patient who comes to my practice, because the message around exercise has not historically gotten the same traction that people have gotten around eating. I'll come to the eating next, but I wanted to show you, this is the exercise guidelines that came out about 2 years ago that increased the recommendations from 30 to 45 minutes for middle-aged people. Now that's a lot of time, 45 minutes, but not everybody can do that. So what do you do if you can't? And this slide shows a study from JAMA that suggests a little bit really does count. So you don't have to kind of understand all the details about this slide, but what this slide is showing is that, let's say we all take about an average of 3,000 steps, 2,000 to 3,000 steps in a really sedentary day when we're not doing much. Increasing your steps from whatever a sedentary person does by only 1,500, 1,600 steps lowers your mortality by 46%, according to this study. And this was for people 72 years and older, and they were studied for a little over 4 years. This is a big study. It was just a study of women, but those women increasing their steps by 1,500, which really isn't a lot, improved their survival. So the women who walked a little bit more did so much better than the women who sat still. There is, if you see, a certain kind of flattening off point, but 66% lower mortality at women 72 years old. That's a pretty great number, no matter how you cut it. So if you find yourself to be fairly sedentary, shoot for increasing by 1,000 steps. This study shows that that matters. So for the physicians, researchers, or science geeks in the audience, this is a study that shows that whether patients lose weight with exercise or not, the factors of hormone regulation and reduced inflammation are really relevant to physical activity. And this slide even includes the cell signaling pathways and the transcription factors that are influenced by greater physical activity. So we've talked about the value of sleep. We talked about the value of exercise. I could talk about each of those for an hour. I could talk about stress management for an hour. But to cast an outline, stress management is balancing your body's instinct to enter a fight and flight situation for survival against against the state where we exist when we want to heal, sleep, connect with loved ones. And we want a balance between the two. Stress is not bad. Stress is an important kind of mechanism that our bodies have for self-preservation. But when we get stuck in the on position, we rob ourselves of time that we need to heal. And this is one of the reasons why coordinated integrative care is so important to me, so that patients don't have a new stressor shouldn't I do this, or shouldn't I do that, or she says I should, or why can't I do this? I want that stress to be managed and those questions to be supported so that patients shift from the fight and flight time into the rest, digest, and heal time. This study in the Journal of Clinical Oncology showed, and this is 2012, but it showed that there were quality of life improvements and mood improvements 3 months after stress management, mindfulness-based stress reduction course. And it included women stage 0 to 3. It was a randomized trial. It was a well-designed trial. And it was sustained at 3 months, which is great news. And we know that a short-term intervention can't last forever. So another study, not the same parameters exactly, but they found that a stress reduction program in this group did not sustain at 12 months. So mindfulness helps quality of life. It may help sleep, may help relationships. And when we know we're in that parasympathetic state, we are likely able to heal better, but doing it short term and then being done with it isn't enough. We have to do some kind of sustaining. But I don't like to raise the bar too high for patients. And I don't like to make them feel afraid that they have to meditate or else, because those are contradictory kind of brain spaces to be. So I like to do, I call it break and breathe. Rather than saving everything up for the end of the day and then salvaging and trying to like rein yourself back in and all of a sudden be calm after being stressed all day, I recommend that my patients are have some levity and some silliness about their mindfulness, because sometimes it's the quiet time with our thoughts that can be the most painful, or when we grieve the most. And having quiet time when we're sick can be stressful. And I don't hear enough people talking about that. And so patients get into a mindfulness state, possibly, but then are uncomfortable when they get there sometimes. With the right support, they can learn strategies to work through that. But not everyone has time to see their acupuncturist and their counselor and their nutritionist and their oncologist and go to work and take care of their kids. It's a lot. So I try to help people prioritize, and I try to look for opportunities where if they can do it, I have them do something once an hour really quickly, or briefly, brightly, take a deep breath every time you wash your hands. A full breath every time you wash your hands, or use an app on your phone if you need it to be external. This is not at all to diminish the professionals who are really, really good. If you have depression, if you have anxiety, if you have hopelessness, I will help you find a professional. But maintenance of your parasympathetic system with some brief interventions throughout your day is also really important. this is my recent favorite thing because it's been so useful for patients. And without seeing the audience, I'm not gauging faces. Normally at this point, I would be gauging to see who's shaking their head or who's looking a little bit vacant. But if you know about this, great, do it right now. If you don't know about this, I'm going to tell you, and I apologize for the quality of the arrows. My 13-year-old wasn't available to help me with that. So what you do is you pick an increment of time, and I usually pick 4 seconds. So you inhale for 4 seconds. Then you hold for 4 seconds. Then you exhale for 4 seconds. And then you hold for 4 seconds. So it's not inhale, exhale, it's inhale, hold, exhale, hold. And it's that hold that triggers the vagus nerve to turn on the parasympathetic system. And I tried this, when I learned about this, I tried it at night when I'd wake up with racing pandemic thoughts. And I was really surprised at how effective it was for how little the investment was for me. So I recommend you try it. On the risk benefit assessment, this is huge benefit, no risk, arguably. All right, now we're on to nutrition. What most of my patients want to talk about is nutrition. As I said before, I think we shortchange the importance of good quality sleep, mental health support, and exercise. But the evidence is here. The evidence for nutrition is for a Mediterranean diet. I like to advocate for a Mediterranean diet that is also a low glycemic index, which means that you get some protein, some healthy fat, and fiber at every meal. As a naturopath, we say it's not what you eat, it's what you assimilate. So I want you to eat well, but I also want you to either do the box breathing or take a deep breath as you eat, because when you're in that parasympathetic state, you turn on all the cascades of processes that help you extract the nutrition from the food that you eat. So eating on the run on your way out the door will not harm you, but you're not going to get the same benefit as when you sit down and eat. So I definitely recommend low glycemic index and a Mediterranean diet. We have lots of evidence for that, tremendous amount of evidence to guide that. There are lots of people who have lots of different opinions, but if you look at all of the evidence we have, it always comes back to the presence of vegetables and the presence of plant-based foods in our diet. I can talk to an individual about whether meat is or isn't good for them, but I worry less about what you're taking out than what you're putting in. On that note, soy. The evidence on soy has been pretty clear for about the last, let's say 10 years, 2009, but there's still confusion. So the evidence for soy is that women with breast cancer, the soy food consumption was significantly associated with a decreased risk of death and recurrence. This was true for both hormone positive and hormone negative. So for the people in medicine who pay attention to hormones, that there was a time when we were worried about soy as a phytoestrogen, and a lot of women were cutting back on lots of estrogens, prescription estrogens, and also worried about soy. And then we learned, actually, when we studied soy, that across the board, pre and postmenopausal, hormone positive, hormone negative, it was either neutral or beneficial to eat soy. I'd recommend eating real soy, tofu, tempeh, miso, rather than processed soy. This is another study that explains how dietary intake of isoflavones from soy was associated with a reduction of all-cause mortality. So we know that you can eat soy. We know that I'm advocating, if you like it and if you're not allergic to it, eat soy. We know that I'm advocating, and the research is supporting the use of a Mediterranean type diet. What's out? Well, empty calories, alcohol, burned meats. So we're leaving summer season, but I really recommend that my patients do not burn their meat on the grill. I could go into the science behind that, but trust me, processed meats, we can see some associations with the sausages and the bacons and the hot dogs. And then fried foods are good to avoid for lots of reasons. This doesn't mean you never can eat them. It means please work your way towards some vegetables so that your serving of fried chicken is a little bit smaller and your serving of the okra is a little bit bigger. I want to make a note here about a condition that's not a real, not a formally adopted term yet, but the term that's used is orthorexia. And there are patients who have such a strong desire to eat well that they wind up suffering side effects from their high standards of eating well. They will avoid potlucks or avoid time with friends or be in a state of tremendous stress because they don't know what will happen if they eat that burger, or they don't know what will happen if they have that piece of cheese. And so for a lot of reasons, I recommend that people pay more attention to what they do eat than being focused on what they shouldn't eat, because it frames it in terms of being empowered and being nourished instead of being harmed. It can be a very, very complicated mental space. And for most of my patients, giving them the evidence, telling them about my expertise and my experience is enough to say, yeah, it's okay. You can eat this food in moderation. It's okay. And then there is a small, and I'm speaking mostly to the physicians and clinicians, there's a small group of these people who there's an underlying anxiety disorder that really needs some support. And then there's another group of these people who are using their virtuous eating to obscure an anorexia. And so you have the training, you can kind of talk with these patients, but if your reassurance and sharing gently of the evidence isn't sufficient, then definitely please ask, get that patient help for the other, comorbidities that they have. And lots of compassion for the patients on that. Now, there's one place I'm less flexible, and the more we learn about alcohol, the less we should be drinking. We know it's a carcinogen. The current recommendation is no more than 3 servings a week for women with breast cancer. Seems like the evidence is showing, up to 5 servings a week for other cancers. Why is it 3 or 5? Well, my sense is that people either drink a lot more than that, like 14 drinks a week, 2 cocktails a night, or they're drinking less than that. So don't worry about whether it's 3 or 5 so much as think about why you're drinking and think about where you can reduce it and ask for help. But there is association now, last update I did with it being a direct or being associated with alcohol, cancer of the mouth, throat, esophagus, liver, colon, and breast. And there are lots of theories about why, but part of it is that there are carcinogenic byproducts of alcohol, and there can be a hormonal impact, and you're generating what's called reactive alcohol or reactive oxygen species when you drink. So give that good attention. Making room for play and making room for joy and friends and love and laughter. Dean Ornish did a study on patients with prostate cancer, but there is some early establishment that if we also budget in time for play, there are some improved biomarkers that show up and actually have some durability and sustain themselves. Okay. We talked about lifestyle medicine. We talked about sleep. We talked about nutrition. We talked about exercise. We talked about stress management. We talked about the physician's perspective and how their practice can be challenging to try to do everything that is needed. And we talked about the patient perspective that is, I want to do more, but how do I do that safely? Kind of the next tier within integrative medicine is thinking about supplements. And I want to start by saying, if a patient's not exercising and is drinking too much alcohol, but taking a lot of supplements, that's kind of the place where I start. Like that doesn't work on our kind of scaffolding of how we look at reducing evidence. So I appreciate the evidence for supplements. I appreciate some of the risk for supplements, but I never prioritize supplements over lifestyle medicine. When we think about what supplements are appropriate, we ask, is it safe? Is it effective? Can I trust the product quality? Is the dose in this capsule accurate? And then as a provider, I ask, is it ethical to recommend this to the patient? And am I putting them at a financial burden? Because most supplements are not covered by insurance. What I'll say about product quality is it's true that FDA does not regulate supplements, but that doesn't mean that supplements are all of problematic quality. And within the industry, there are some specific companies and some specific organizations that do exceptional quality testing, exceptional dose accuracy. They're transparent. And those are the companies that I usually recommend. So it's not true that supplements are not regulated. It is true that they're not regulated by the FDA. These are examples of the supplements that an integrative oncology clinician may reasonably consider. And I say reasonably consider because they tend to work either really well for managing side effects. They tend to have, or they might have some overall survival benefit. They tend to be things that are safe when used with supervision. And they are the things that have tremendous amount of evidence. Many of you might have heard about the VITAL study out of Brigham and Women's. This was really interesting, so much controversy over this study. Different news outlets and different subspecialty groups had completely different summaries of this study. The primary endpoints showed no benefit for reducing, the things that they were looking at. However, they did find some things that are worth studying some more. They did find that vitamin D was associated with a decreased risk of recurrence in people who have had cancer. So if you have or have had cancer, it's worth getting according to this study, and based, in my opinion, on the low cost and low risk, it's worth making sure that your vitamin D is in normal range. Omega-3 fatty acids. Did not reduce the risk of stroke or cancer, but in people who have had cancer, reduced the risk of heart attack or a cardiology intervention like a stent placement. So because most of my patients are patients in the oncology, having an oncology diagnosis, these are two of the things that the evidence supports that I look at with them. And really interesting was, even though it wasn't a primary endpoint, 77% reduction observed when good quality fish oil were used in the African-American population of this study. That's a 77% reduction. That's worth paying attention to. And while it might not be exactly the most pristine, robust kind of study design to find that result, which the scientists in the room might be thinking about, certainly as a clinician with African-American women in my practice, I can't ignore how compelling that is. And then I weigh the risks and benefits and financial strains, and then I'm transparent with the patient. But I think that's worth, in my practice, I will look at this and I will be an early adopter of information that shows me such a great benefit. One of the reasons I like vitamin D is because whether it reduces risk of recurrence or not, and that's very important, it reduces vitamin D deficiency is permissive for exacerbation of a lot of the symptoms and side effects that patients experience. Joint pain, hot flashes, depression, anxiety. If we can just correct that because your vitamin D is low and we just bump you up 10 points in your normal range and your symptoms go away for like $3 a month, that's the kind of easy big change, low risk opportunity that I look for in my practice that can get missed if somebody's not taking the big picture look. I talked about melatonin before, and I just want to say I don't recommend that patients self-dose on additional melatonin beyond 3 milligrams, let's say. And you should always speak with your own doc. But in these studies, melatonin used under physician supervision at a higher dose had some benefit. So we think about, is there actually science to support some of these supplements that these integrative oncology providers are using? And yes, there are lots of human clinical trials. At least half of them are randomized. Some of them are meta-analysis or review articles, and that's good. That's good, strong science. This is just one quick try to demonstrate, and I think I got, did I get this backwards? Conventional, yeah, I got this backwards. Conventional treatment alone compared to conventional treatment with melatonin. So when people got standard of care and included melatonin also, their fatigue, low platelets, neuropathy were diminished versus the people who did not take melatonin. So overall, big picture, an integrative clinician coordinates all this stuff that's at the bottom of your screen right there. So I meet with my patient, the other providers kind of regionally who work in this field will take an inventory, just as a primary care doctor might do, like what's going on with sleep, exercise, diet, nutrition, but then put an oncology lens on it so that we can help you, because you can't go in any given month to the health coach and the dietitian and the Reiki provider and the acupuncturist and the physical therapist and go to church and see your therapist. So you can't do all of that. And there are patients who try, and it's a diminishing return, and it creates stress and anxiety, and it's not beneficial. First, do no harm. So if you want to be proactive, or if you have a patient who wants to be very proactive, please help them get some guidance on how to triage and prioritize all the different things that we have evidence for that are available to them. And UVM has plenty. So no need to be controversial or have outrage. This book is a little bit old, but shows lots of good information about how to prioritize. It's more directed towards the patient. And then this book is more directed towards the provider. This is Don Abrams has spoken at UVM and done some good continuing medical education. Andrew Weil, many of you know, but this particular book is quite useful. I had the privilege to write the integrative oncology chapter for the Andrew Weil integrative geriatrics textbook. So I think we're at the end of time here. And I will just scroll through these last, this is my colleague, and we're in Middlebury, and thank you very much.